members for starting such a fantastic event during this difficult time. So we're all at home and some people are working on shift basis. I think with this, I would like to present today about management of PPHN in NICU level 2. So I would start basically my flow of presentation will be a brief introduction, fetal circulation, pathophysiology involved, and etiology, basically touching what are the reversible causes of PPHN, how to diagnose PPHN, what are the current therapeutic evidence-based management, and I'll conclude. Slides. Sorry, the slides are not moving over here in the computer.
ಅದೇ ನಾನು ಮೀಟಿಂಗ್ ಇದ್ದೆ ಈಗ ಅದಕ್ಕೆ ಪೆರ್ಸವಲ್ ಹಾಕಿದೆ ಈಗ ಹಾಕಿ ಒಂದು ಕಾಲು ಗಂಟೆಯಲ್ಲಿ 99.2 ಇವನ್ ಕೆಲಸ ಮಾಡೋ ಸರ್ ಸರ್ ಆಂಟಿಬಯೋಟಿಕ್ ಅಂತ ಹಾಕ್ಬೇಕು ಅಂದ್ರು ಸರ್ ಅವ್ರು ಫೋನ್ ಎತ್ತುತ್ತಿಲ್ಲ ಎರಡು ರಿಂಗ್ ಅಲ್ಲಿ ಕಟ್ ಮಾಡ್ತಾರೆ ಒಟ್ಟು ಎಲ್ಲ ಬಿಜಿ ರೋಗ ಮಾಡು ಇದು ಜಾಂಡಿಸ್ ಇದೆ.
Okay, I would continue. So we all know that the neonatal PPHN is quite a common condition in the NICU. So it contributes around 18 per 1,000 live births. This is a overseas data causing hypoxic respiratory failure. Out of that, 10% of the neonates with respiratory failure have pulmonary hypertension. The incidence is as close as 2 per 1,000 live births. And the mortality is around 8 to 15%. And nearly it was around 50% in early 80s. What we don't know is the impact of this pulmonary hypertension during the early childhood and late, childhood and even in adults. So there's a lot of research going on, and probably we'll get the data as the year passes on. I would like to present my presentation just with a brief, introduction of what happens at the gas exchange, at the gas interface, alveolar gas interface barrier. So this is an electronic microscopic appearance of the alveoli as well as the pulmonary capillary within the alveoli. So you can see that it is such a thin barrier. It measures only 0.3 micrometers. And what you can see there is a pulmonary capillary with a, red blood cell, which is dumbbell shaped, and the alveolar epithelium on the other side and the capillary endothelium inside. And in between the interstitium and also the surfactant layer over there. So the diffusion of gas happens at this level. This is where the oxygenation happens at the pulmonary capillaries. So it's such an important slide to understand, what happens in pulmonary hypertension is purely hypoxemic changes due to severe pulmonary vasoconstriction, and probably also an element of atelectasis where there's no diffusion of gas. This is another slide which represents, how the capillaries look in a microscopic section. You can see a well aerated lung there, and you can also see pulmonary capillaries. That you can see the red blood cells, flowing through that. And this is a slide where you can just imagine you're sitting inside the alveoli and you see externally how it looks. So basically, you can see the pulmonary capillaries there, the pulmonary artery, and the pulmonary veins. So this is a complex structure. This is in one alveoli. So you can just imagine there are multiple alveoli and the surface area involved with gas exchange. Now, just coming to the definition of PPHN, so it's a failure to achieve the normal decrease in PVR at birth, leading to a very labile systemic arterial hypoxemia. And this is due to altered pulmonary vascular tone, reactivity, or structure. As a result, there is resulting right to left shunting across the ductus arteriosus as well as the foramen ovale. Now, a brief introduction of the fetal circulation, because it's quite important to understand what happens during the fetal life, and as the baby is born, what is the transition which happens. So what you can see there is the oxygenation of the blood which is passing through the ductus venosus from the placenta. The concentration of oxygen is around 45 to 50 millimeters of He, and the SpO2 is around 50 to 60%. So the blood travels through the ductus venosus to the right atrium, to the porphyrin ovale, to the left atrium and left ventricle, and then to the ascending aorta. So mainly a concentrated part of the oxygen is delivered to the brain and to the myocardium. The other parallel circulation, where the blood from the lower part of the body is drained to the IVC, right atrium, right ventricle, through the ductus, it gets into the descending aorta. So if you look at, only 16% of the total cardiac output is drained to the lungs in the fetal life. So this is a parallel circulation in the fetus. Now, what happens when the baby is born after birth? So there is a tremendous expansion of lung as the baby starts breathing. There's a rapid drop in the pulmonary vascular resistance. There is increased pulmonary blood flow to the time of 10. Then spontaneous closure of PDA, which occurs soon after birth and continues to close or become narrow over time during the first few hours and then later part of the days. And the ventricle starts functioning, increasing the cardiac output. Now it becomes more of a series circulation rather than a parallel circulation. And consequently, there is an increase in systemic vascular resistance. That slide depicts what are the changes which happens in utero as well as when the baby is born. So there is change in pulmonary vascular resistance and the systemic vascular resistance at various gestation. And when if you see here, the first left half of your slide shows at various canicular, saccular, and alveolar stage, the pulmonary vascular resistance is quite high. And that is mainly due to the low density of the vasculature, increasing vascular density, and due to a decreased oxygenation in the fetus, there's active vasoconstriction. So as soon as the baby is born, you could see that there is a drop in the pulmonary vascular resistance, and consequently there is an increase in systemic vascular resistance. And this is what happens as soon as the baby is born. What you can notice is babies who are born by vaginal delivery, they drop their pulmonary pressure quite significantly compared to babies who are born by cesarean section, or they have any underlying lung disease, or if they're born preterm. So these are the 2 points where you can see a drop in the pulmonary vascular resistance and increase in systemic vascular resistance. Now, when you look at the baby and you measure the pulmonary parameters in the fetus near term compared with the 3-day-old neonate, you could see there is a change in the pulmonary, arterial wall thickness, and it is kind of represented as 3% compared to 6% in the fetus. The pulmonary arterial pressure drops to 20 from 55. The pulmonary blood flow, which was around 138, increases by 2 folds to 245, and the pulmonary vascular resistance also falls significantly. So as soon as the baby is born, there is rhythmic respiration. So when the baby starts to breathe, then there is also an oxygen tension buildup in the alveoli, and both these 2 factors decrease the PVR, and there is increased flow of blood to the pulmonary vascular resistance, and the vascular resistance fall, and there is going to be vasodilatation in the pulmonary bed. Now, when you come to the pathophysiology, the changes happen predominantly in the pulmonary vasculature. The changes can be in the lung, and also they definitely these 2 contributing factors can cause some changes in the cardiac cycle too. What happens in the pulmonary vascular bed is more of the smooth muscle thickness. We all know that as the smooth muscle thickness increases, there is going to be increased PVR. So at the same time, if there is a decrease in the pulmonary, in the smooth muscle thickness, there's going to be a decrease in the pulmonary vascular resistance. Any failure to achieve this is going to lead to PPHN. The muscularization of this smooth muscles can extend to even periphery, causing even more harm to the baby, leading to kind of retractable PPHN. Now, what happens? What are the things which can change in the lung is what determines the outcome of most of our babies when we manage PPHN. So these are called as secondary changes in the lungs. It can be because of meconium aspiration syndrome. It can be because of pneumonia or sepsis. It can be because of respiratory distress syndrome. It can be because of transient tachypnea of newborn due to retaining of lung fluid, or it can be because of a complex condition called as congenital diaphragmatic hernia. Let's say you see a lung and there is an element of PPHN, but the lung looks fine. Then this condition is primarily because of primary PPHN, or we call it as idiopathic. We don't know the cause of pulmonary hypertension. When you look at the X-ray, the X-ray looks black, and now the new terminology is like called as black lung PPHN. Now, what happens in the heart during PPHN due to high vascular resistance is a shunting of blood, either extrapulmonary or intracardiac. So extrapulmonary is mainly a shunt across the ductus arteriosus, where there's going to be a differential cyanosis. The right hand and the lower part of the body have a difference of saturations. But when there is mixing of blood at the foramen ovale, the baby tend to have the same saturations. Not only it causes the differential saturations, due to increased pulmonary vascular resistance, there is increased pulmonary arterial pressure, which causes pulmonary insufficiency, leading to the right heart failure. So by the baby as such will have right ventricular hypertrophy, and that can lead to tricuspid regurgitation, and the intraventricular septum bulges to the left and causes left ventricular dysfunction. So you start with a right ventricular dysfunction, and then you go into a left ventricular dysfunction, and this is what happens in biventricular dysfunction in these babies. So not only that, they can land up with decreased systemic blood pressure as well as systemic vascular resistance drop. And this is particularly seen in babies who are prone with a history of sepsis, or if they are in septic shock, and that is one of the cause for pulmonary hypertension. Now, based on the etiology, we can classify pulmonary hypertension mainly into 4 types. One is because of maladaptation, as I mentioned earlier, because of meconium aspiration or respiratory distress syndrome or pneumonia, where there is poor adaptation because of a secondary injury to the lung, or there is a problem with maldevelopment where the pulmonary vascular bed is remodeled, and these are the babies who are highly difficult to manage initially, and they might require longer time to come out of mechanical ventilation or all the medications what we use to treat for PPHN. This is what is classically called as idiopathic or black lung PPHN, or the lungs are maldeveloped or underdeveloped, this secondary to congenital diaphragmatic hernia, or when the fetus have severe oligohydramnios secondary to renal disease, or there's prolonged rupture of membrane. So these babies, when they're born, they have very less surface area of lung, and the pulmonary vasculature is not developed or underdeveloped. There's another entity called as obstruction. There's sludging of pulmonary vascular blood, and they can cause obstruction due to polycythemia and hyperviscosity syndromes. So based on the etiology, we can classify according to what type of pulmonary hypertension it is. Now, coming to the etiology of pulmonary hypertension, what we are today focusing on mainly on acute causes, which are reversible, and which are reversible based on the pulmonary cause or non-pulmonary cause, like hypoxia, like birth asphyxia can lead to pulmonary hypertension, or some late causes like infection, where pulmonary hypertension can be one of the causes where we treat them. Now, when you look at the causes, 42% of pulmonary hypertension is because of meconium aspiration syndrome. 17% of them is because of respiratory distress syndrome. and the primary PPHN contributes around 27%. Infection can be, one of the cause as pneumonia and sepsis, which contributes to 17%, and around 1 to 2% is where there is problem with the lung development, or we call it as lung hypoplasia. These numbers are kind of taken from the Western literature. I think there is going to be definitely change in terms of mechanism aspiration and infection as the primary cause, along with RDS in our country. When you put all these etiologies and the type of pulmonary hypertension, either PPHN due to secondary causes or a chronic progressive, and the evidence what we have in terms of treatment, what is most important in this slide is to see what are the outcomes in a child with pulmonary hypertension. What surprises is around 25% of these babies can have long-term neurodevelopmental impairment. In comparison with babies who are born with chronic progressive, babies who have been diagnosed to have chronic pulmonary hypertension, the mortality is as high as 40 to 60%, but the long term is poorly documented or is being recorded. So there's a lot of data we need to look into it, what happens to these babies, but there is significant long-term neurodevelopmental impairment in these babies who survive. Now, how do we diagnose pulmonary hypertension? So basically, it is more of clinical diagnosis as well as supportive diagnosis. Whenever you see a child who have disproportionate degree of hypoxemia compared to the lung disease, and there is severe desaturations, probably you think of two causes. One is either it is PPHN or it is something related to congenital heart disease. If you're good at auscultating and if you could appreciate a loud P2, that indicates there's severe pulmonary hypertension. On the bedside, you probably can see, the pre and post ductal saturations, and if the saturations are more than difference is more than 20%, the right radial artery saturation as well as one of the limbs in the lower limb, then probably it indicates there's significant ductal shunting, and that is what is contributing to differential cyanosis. But keep in mind that if there is no lack of differential cyanosis, that doesn't exclude PPHN. So you still probably have to diagnose by doing an echocardiogram. A lot of people used to do this hyperoxic test. Nowadays, because of easy availability of bedside echocardiography, and most of the neonatologists are now trying to look for the pulmonary hypertension. So this we generally don't do, but in centers where there is no echocardiography, you can do this blood test, do an arterial gas, preferably the right radial artery, and see what is the PaO2s. If the PaO2s are more than 150, most of the time you probably can exclude the congenital heart disease. But it doesn't mean that there are some of the congenital heart disease where the PaO2s may be still less than 150, and we need to have echocardiography to clearly say that 100% this child doesn't have congenital heart disease. So the gold standard remains 2D echocardiography. What I would like to bring at this point is when you do an echocardiography, you probably are measuring the pulmonary pressure, the pulmonary flow. So you can always try to see what is the pulmonary pressure. And imagine if the pulmonary pressures are too high and there is increased pulmonary flow, then you probably have to think of increased flow to the pulmonary circulation, like which happens in VSD and PDA. Let's say if there is increased pulmonary pressure and at the same time you have increased pressure, having PAPVC often mitral stenosis. So these are two things which you probably have to, try to think of as a concept. So they're going to have a cardiography.
Guys, sorry, there is somebody whose song is coming up. Can you please mute all the rest of the videos?
Sorry about that. So tomorrow there's going to be a talk by Dr. Venkatesh and Sidhu. They are going to talk about echocardiography, and I'm sure they'll put on a lot of, the clinical aspects as well as how to kind of evaluate pulmonary hypertensions in babies. So you can also measure the pulmonary systolic pressure And what we see in most of the babies when we do an echo is either the pulmonary pressure is, iso or suprasystemic. Now, on the bedside, you probably can look at what is the oxygenation index. It's a very useful tool. It will assess, what is the severity of pulmonary hypertension. And it is a simple formula which can be applied on the bedside. It is basically calculated by the mean airway pressure times the FiO2 times 100 divided by the arterial PaO2. So based on the oxygenation index, it's been classified as mild less than 15 or equal to 15, moderate more than 15 to 25, severe more than 25 to 40, and quite critical or quite severe between 40. There's another parameter which you can look at the bedside, which is oxygenation saturation index. It's the same as oxygenation index. Here you divide by the pre-ductal SpO2 instead of PaO2. So this value corresponds nearly to the half of what the OI index is. For example, if the OI index is 20, then oxygenation saturation index is around 10. But there's not enough data or large studies which has used this as one of the bedside tool to assess the severity. I'm sure over time we probably would come up with more data on that. There's another parameter we can measure is the an alveolar oxygenation gradient. Again, it is a formula which has been, over there. We can kind of calculate this. Basically, it is around 10 to 15. As the alveolar oxygen gradient increase, that means there's not much of enough alveolar ventilation happening. So that probably tells us there is severe pulmonary hypertension or there is some pulmonary pathology which has been involved. Now, how do we assess a neonatal pulmonary hypertension? So it's a basic logarithm where you look at the airway, you look at the alveolar recruitment, whether they're recruited well or not, see the underlying pathology, and assess the pulmonary blood flow, assess the level of, and also assess the cardiac evaluation, whether the filling is good, actually you pull out structural abnormality. Now, what are the therapies we have in pulmonary hypertension? So there are various therapies which have been tried. One of the common therapies which I have mentioned over here is this. So you start with delivery room resuscitation. They give adequate P to expand the lungs. Then you start these babies on CPAP if they have respiratory distress. If you know that they have surfactant deficiency, you probably administer surfactant to recruit the lungs. And you use conventional ventilation. And if you are not able to ventilate and achieve what you're supposed to achieve, you probably may have to think of moving this baby on high frequency ventilation. Now, what are the medications we have to selectively vasodilate if you have diagnosed pulmonary hypertension? So basically you vasodilate, and another one of the gas which we use is nitric oxide. Now, what are the other support in terms of heart we can use? We can use pressors like inotropes, and we use milrinone. When we use all this intervention and the child is still sick, that indicates this child is quite severe sick. So these are the ones with the oxygen index of more than 40 would land up on ECMO. Now, coming to the oxygen therapy, there's a lot of studies have gone over the last 10 to 20 years. We all knew that oxygen was an important determinant of pulmonary vascular resistance to fall. As the oxygenation increased, the pulmonary vascular resistance used to fall. Then supplemental oxygen was the mainstay of therapy for a lot of patients with hypoxic respiratory failure and PPHN. But we also know that hypoxia is one of the main factors which can cause pulmonary vasoconstriction. Now the question is, what is the optimal PaO2 or what is the optimal saturation? To answer this question, I would like to present few data which shows that this is one of the articles which has clearly shown that the mean arterial pressure drops significantly as the PaO2 increases somewhere around 40 to 50. This again an animal module, and it shows that as soon as the PaO2 reaches around 40 to 50, the pulmonary vascular pressure drops. Again, further to substantiate what the few other papers said, they looked at 10%, 21%, and 50% oxygen and saw what the pulmonary vascular resistance happened when the arterial PaO2 increased. And you could see that significant pulmonary pressure was decreased as the PaO2s were around 50 to 100. But if you see some of this, even if the PaO2s are like 100, 150, there was not much of any difference. So it again indicates that if the PaO2s are somewhere around 50 to 60, that's as well as good. That probably have achieved what you would like to achieve. Now looking at what happens when you give nitric oxide from the baseline value of pulmonary vascular resistance when these subjects are being exposed to 100% oxygen in response to nitric oxide. What you can see is there's a definitive drop in the pulmonary vascular resistance when you start nitric oxide at 20 parts per million from the baseline value. But as soon as the nitric oxide is stopped, within 10 minutes, there is rebound hypertension, pulmonary hypertension. And what you can see is the individuals who were given 100% oxygen had a very significant rebound of pulmonary hypertension compared to individuals with 21%. So again, it shows that oxygenation may be good, but the rebound effect is quite drastic there. Now, what about the SpO2? What are the saturation which we can aim for? Again, the pulmonary vascular resistance falls significantly when the saturations are around 90 to 95, 96. So initially, when the saturations are high and low as 80, 90, the pulmonary pressures are quite high. And any marginal increase in the saturation is not going to drop further the pulmonary pressure. In fact, we can see a moderate rise in pulmonary vascular resistance. Why is this too? Is because a lot of studies, we all know that now oxygen is no more considered as a safe gas because it induces free oxygen radical, and causes reactive oxygen species. They are all potent pulmonary vasoconstriction. So they are like isoprostane, peroxynitrates, and hydrogen peroxide. So they cause the pulmonary vascular bed quite, make the vascular constriction and increases the further the pulmonary hypertension. Now, when you measure this oxygen-free radical in a term baby which is being resuscitated with 100% versus 21%, you can see it takes a couple of days, even months, for the free radicals to come down. So this is the paper which has been published in Journal of Neonatology. We looked at what is the severity of this injury when you use 100% oxygen. Now, as I told you earlier, oxygen was a fantastic gas, saved a lot of children and adults. Of course, we need to use with caution. So with this, what can we learn from oxygen? So you start resuscitating a term baby with 21% FiO2. Avoid both hyperoxia and hypoxemia. There's no further improvement in PVR, even if there is an increase in PaO2 more than 60. So try to achieve a PaO2 somewhere around 60 to 70 or 80. That should be good enough. Try to wean the FiO2 before weaning the nitric oxide, and try to keep the saturations on this baby between 92 to 97 pre-ductal. Now, coming to the respiration, mechanical ventilation, most of the babies require either a CPAP, non-invasive, or a full mechanical ventilation. On those babies, if you look at this slide, you can see at extreme ends of ventilation, either you underventilate or overventilate, the pulmonary vascular resistance is quite high. Which is the best spot, or which is the best place to ventilate these babies is where the FRC is met. So at eye extreme, either you ventilate, hyperventilate, or you underventilate. There's always a chance of these babies having severe pulmonary vascular resistance by stretching these alveolar vessels or the capillary blood vessels, which is being depicted on the slide. So you need to find a sweet spot to ventilate. Most of the time, clinically, it's very difficult to find, but I think with proper clinical judgment, with the blood gas and staying next to the baby and try to achieve what you want to achieve clinically as well as on the blood parameters, probably you know that where you are ventilating, and then as the baby improves, probably you can come down on all the ventilator settings as the pulmonary vascular resistance falls. Now, so what do we have in terms of mode of ventilation? We have non-invasive ventilation for milder cases, and we can use CPAP, low flow, high flow, whichever the unit protocols or policies you have. And some units do have non-invasive ventilation. They try that. So whatever you use, try to assess these babies quite regularly so that you don't land up from mild to moderate and severe PPHN. So it's a continuous process of assessment. So keep on checking these babies as they progress. If they improve, great, you know that you are doing. If not, then you need to take a decision whether you need to ventilate them. If you ventilate them, most of the centers we use synchronous volume guarantee so that you have a homogeneous, expansion of the lung or the alveolar area. What commonly people do ask is whether we ventilate on a conventional ventilation, whether we can use nitric oxide. Yes, of course we can use, but you need to make sure that the ventilation happens well, all the alveoli is open, you recruited the lung, then only the nitric oxide works. If it is under-recruited or over-recruited, probably nitric oxide doesn't work. So when you hit up wall against, and then this, if the ventilatory pressures are quite high, you're not able to achieve, then the next option is using high frequency or a jet ventilator or oscillator, whichever you have in your unit. Along with that, we use nitric oxide. And this is what is the best modality for treating a very severe PPHN, where high frequency helps to keep the lungs open up, and you try to use the gas, then there's diffusion of this nitric oxide gas, and there's going to be decrease in pulmonary vascular resistance. Now, when you ventilate, what do we use surfactant? When should we use? Probably this slide will answer. Now, this is a paper by Kandori, which has been published in 2004 and 13. What they looked at is a different, primary diagnosis like meconium aspiration, PPHN, and sepsis. When you give surfactant, you saw that there's a decrease in pulmonary vascular resistance, the PPHN drop. When the same data, when they looked at it, when the surfactant was used earlier, like less than, if the oxygenation index is between 15 to 25, they saw a significant drop in the incidence, or they came out with pulmonary hypertension quite significantly earlier compared to when you use surfactant with a higher oxygenation index. So what basically it means is, if you're using surfactant, use very early, not after 48, 72 hours. What they found was a threefold reduction in the risk of ECMO and death. That's quite significant. I think a lot of centers do use surfactant, especially when you know that the lungs are stable, or any etiology, either RDS, which we commonly use, or if even in meconium aspiration syndrome, we do use surfactant because meconium do deactivate surfactant. So if you administer surfactant, it will probably recruit the few of the alveoli which are opened up. Now, what are the other therapeutic options which are available to manage PPHN? So we have few drugs which have been commonly used. Few of these drugs are sildenafil, bosentan, milrinone, glucocorticoids, and prostaglandins. So these drugs basically act on the pulmonary vasculature, and they act at cyclic GMP level, cyclic AMP, and endothelial pathway, either by mediating them or their derivatives, or they inhibit. So the next slide shows at different levels where they act. So what do we have? We have prostacyclin, prostaglandin, and milrinone, which basically milrinone is one which acts at PDE level, that is cyclic AMP level. We have sildenafil, which acts at PDE5 level, that is phosphorus dienestase 5 enzyme inhibitors. And we have ET receptors, endothelial receptors like bosentan, and we have Rho kinase inhibitors. Out of this, only few drugs have been used in pulmonary hypertension. And what the next slide shows is the evidence-based medicine. So the things which have been marked in blue have large-scale RCT trials and meta-analysis. What are those? They are oxygen and Indian nitric oxide. There's no doubt about that. And we discussed about oxygen. Nitric oxide, I'm going to discuss probably with the next episode. I was told to discuss only level 2. So, and I think most of the level 2 don't have nitric oxide or high frequency, so that I've kept it for the next presentation. What do we have? The small RCTs are the sildenafil and bosentan. Only few case reports of case series with use of milrinone, prostacyclin, and prostaglandin. So when you look at sildenafil, we know that it is PDE5 inhibitor. It selectively reduces both PVR in animal module and adult humans. And it has been reported to be very successful in the treatment of infants with pulmonary hypertension due to various other causes. There is 3 studies which looked at it. They did a systemic review and meta-analysis in 77 patients when they had used the enteral sildenafil. What they showed is a reduction in mortality and improved oxygen level. And all these 3 studies were done where there was no nitric oxide and high frequency. The same thing, Steve Horn looked at use of sildenafil intravenous, and what he did was an open label dose escalation study, which looked at IV infusion of sildenafil for babies between 48 to 7 days of age with severe PPHN with the oxygenation index more than 50. So in these babies, when they started, there was a significant OI improvement by 10 points. From 29, it dropped down to 19. But what they found out was a severe hypertension in 5 of those babies. And they have to stop this study. Though the FDA doesn't approve, the American Heart Society and the Thoracic Society do recommend as an adjuvant therapy for in babies who have refractory to INO therapy. So it may be considered in resource limited setting. And I think most of our Indian units do use sildenafil, and IV sildenafil is easily available. So the indication for sildenafil is as adjuvant in INO resistant PPHN to facilitate weaning from INO. So you started INO, you're coming out of INO, then you need to start with sildenafil, you can start using it. And patients where there's contraindication of using nitric oxide, in those conditions you can use sildenafil. And there's a trial and a lot of studies which have come out, use of sildenafil in chronic pulmonary hypertension like BPD and congenital diaphragmatic hernia. So when you start using sildenafil, the dosage, what is recommended is 0.5 to 2 milligrams per kg per dose in every 6 to 8 hour dose. And if you're using as an infusion, it is recommended as 0.4 milligrams as loading, then as an infusion around 1.6. But keep in mind that this can cause significant hypotension that shouldn't exacerbate hypertension. So be careful when you're using IV sildenafil. The next drug which I would like to discuss is milrinone. It's a PDE inhibitor. Basically acts by increasing the cyclic AMP. It is both inotropic and lysotropic and an inodilator. So it is very good, especially when there is ventricular dysfunction, especially the left ventricular dysfunction. And it acts very well with INO when you use it. But there are not much major studies. I could find out only 2 randomized clinical trials, a small, 2 small case series trials too. The efficacy and safety of milrinone in newborns is not extensively known. There are a lot of studies going on currently. We'll hear this in the next coming couple of years about the rampant use of milrinone. So currently, what they recommend is whenever there is a ventricular dysfunction with PPHN, which we commonly see in sepsis, asphyxia, or congenital diaphragmatic hernia. So in those conditions, probably you can use, provided you have a good systemic, SVR. If the SVR is low and the blood pressure is low, be careful using milrinone. So the loading dose is 50 mics for 1 hour, and we generally infuse as 0.33 to 0.99 mics per kg per minute as a continuous infusion. The next drug, what I would like to discuss is bosentan, which is quite rapidly used in infants and in children. It is an endothelial 1 receptor antagonist, and there are only few studies which have been used in neonates. A single trial of 47 units with PPHN in a setting of where there was no nitric oxide or ECMO was used, and what they found was a significant improvement in the OI index and oxygen saturation. But at the same time, when they look at the small trial of 21 infants, didn't make much difference. So definitely, you can think of using this even, which is used for the ductal patency, is quite available, but other medications like preprazole, iloprost, epinephrine, and beroprost are not commonly available. They are given at different modes like oral, intravenous, or subcutaneous, but had only one experience in overseas, but not in India. I'm sure same thing would apply to a lot of us who practice in India. Now, coming to the most important factor, a lot of people would probably need to understand the RV dysfunction is one of the most important things with severe pulmonary. How can we optimize the RV preload? Be very careful using, judicious boluses. So be cautious using epinephrine, which we are come out of dopamine mainly because it has alpha effect and also has effect on cardiac contractility. So epinephrine is a good choice, or a non-epinephrine is a good choice. To reduce the to reduce the RV afterload reduction, one of the most potent gas is nitric oxide. But in centers who don't have nitric oxide, you can, if the blood pressure is good, you can think of using milrinone. And if the ductus is closed and you want to kind of open the ductus so that you have a pop-off valve so the RV gets underload, then you can think of using prostaglandin E1. So today, what I have discussed is basically managing PPHN in level 2. I have not touched in detail about nitric oxide, how much to use, when to use, and how we can wean from nitric oxide. Use high frequency ventilator as the mode of ventilation. So I haven't touched about high frequency ventilation, how you set up a high frequency ventilation, which are the ventilators we use. And so hopefully, if given an opportunity, probably the next episode, I would like to discuss with that. And also the ECMO part of it, briefly, I would like to discuss. So with this, I would like to conclude with few of my take-home points. So in the current era, oxygen, though it's been rampantly used, it's a very good. Try to keep the saturations between 92, 93 to 96, 97. Try to aim the PaO2s around 60 to 70. Try to get the most important thing in my management of pulmonary hypertension is to get an arterial line. And it is always to get the pre-ductal arterial saturations of the gas. So if the unit are good enough to place a right radial artery, it is fantastic. If not, don't worry, you can always put a UAC, and you probably get the mix at, the saturations, the oxygenation level, PA would be slightly low, but that will give you a guide what is the change in the ductal level, the shunting. So if you're trying to give, if you ventilate, if you want to give surfactant, give as early as possible based on the lung parenchymal illness. So if it is RDS, sure, you probably can think of giving surfactant. That itself would probably try to use it very early. And we have seen that if you use surfactant and when early, if oxygenation index is less than 15, it does improve the pulmonary vascular resistance. most of the centers, when you don't have nitric oxide, you can think of using sildenafil, but be cautious about it causing systemic hypotension. And if you have used nitric oxide still, you're not able to achieve what you are, and it is refractory nitric oxide, try to use sildenafil. And when you're coming out of nitric oxide, you can use it as adjuvant. Milrinone, fantastic drugs. A lot of cardiology and cardiac centers use milrinone as one of the inotropes because it has both inotropic and lusotropic effect. But be sure that the systemic pressures are good and the LV function, if it is poor, try to use that. Over time, you would see the improvement in the left ventricular function. As I told you earlier, hydrocortisone, though some of the centers do use, but make sure that sepsis is being ruled out before you use hydrocortisone. So as I told you earlier, probably we'll see whether we can cover this with the next episode. Because of lack of time, I was told have 40 minutes to 45 minutes, then discussions across all the senior neonatologists who have joined us today. I can discuss about this with the next presentation. So to end, I thank you all for joining today. I know you've taken off your time on Saturday evening. Thank you. And thanks to the NNF Karnataka chapter and Dr. Kotreshi sir for giving me this opportunity to present. Thank you.
Sir, thank you very much, sir.
But because the level is high, no, so to do it again.
Thank you very much, sir.
Urine
There are few queries which have come up.
Yeah, urine routine, instead of routine, urine for bile acid something it will come. No? That's the one I'm reducing substance.
First, hello, sir.
In the morning. From
Hello,
the casualty,
sir.
I think it
Can
might
you hear
be
me,
in the
sir?
lab only.
I
So
can
they
hear you.
have to tell them, along with that, they have to add TMS in the newborn screening. Understood, no?
I can hear you, Prashant.
If they have any
Sir,
queries,
first
they can call
question.
me. Just tell
Role of
them
max
newborn
sulfate
screening has
in
come
PPHN.
from the casualty in the morning. In that, we want TMS also.
Aman, mute all the thing, no? We'll just take one by one questions. Yeah, sir, can you hear me, sir?
Yes, I can hear you now.
Sir, role of max sulfate in PPHN. That's the first question which has come.
Yeah, so there are a few studies which have come up over the last few years, especially over the last 5 to 6 years, the role of magnesium sulfate in PPHN. So yeah, definitely if you are run out of options, you can think of. Again, you need to be very clear, sure about the systemic hypertension which can cause. So you need to be sure when you have used all the sildenafil part of it, you have used all the modalities to treat the PPHN, you run out of option, you can think of using as a loading dose and see whether it gets better. No doubt about that.
Okay. So the second question is,
Yeah.
according to your experience, sir, is there any difference between using different surfactants available, commercially available different surfactants? Is there any difference?
Well, if we know that people have individual preference and individual experience, but if you look at most of the naturally occurring surfactant, either servant or curacao, either which is bovine or porcelain induced, both are quite efficacious in terms of opening the lungs. What basically tells the papers which have used surfactant in management of PPHN, they don't mention about whether it is natural or synthetic surfactant. What they say is, if you're using surfactant, use within the first 12 to 24 hours, not like more than 2 to 3 days when the hypertension is too high.
Okay, sir. The next question is use of sedation and muscle relaxation.
Yeah. Well, yeah, sedation definitely when these babies are on high frequency, we probably should use. And most of the centers either use fentanyl as the first line or they use morphine. In terms of muscle relaxation, that has been kind of not encouraged. It doesn't mean that people don't use it. I can still see some of them use when they think that the baby is not, kind of totally cooperating in terms of managing. what happens is, one, of course, if the baby is very agitated and jumping around, you don't have adequate sedation at the same time, the baby is moving, the pulmonary hypertension component can increase. But with a good analgesic and a sedative effect like fentanyl or morphine, you probably can escape using muscle relaxant. And that itself can be kind of what happens is it decreases the vascular tone. You may have to increase the vascular tone by pumping in more fluids. You may have to increase the ventilatory settings. That we know that over time, it not only in PPHN, a lot of patients, we don't use muscle relaxant as freely as what we used to use 10 or 20 years back.
Okay, so one more question is, would your management vary if you have a baby with severe HIV needing cooling and severe PPHN? Would you transfer to a tertiary center needing nitric oxide?
Well, if you are cooling, if the baby is not ventilated and you think you have achieved what you want to achieve in terms of saturation and the PaO2s, and if you could have a facility where you yourself or somebody could do an echo and say that pulmonary hypertension is very mild or moderate, I'm not bothered, and you have an access where in case if it deteriorates, I can share. That's a good choice to keep the baby there and continue cooling. But on the other hand, you have started cooling, the saturations are not great, you may have to ventilate, the pulmonary pressures are quite high, it's becoming as such cooling can increase the pulmonary pressures. Then you probably have to take a decision because that is the time where if you want to shift, you have to shift early so that we start using nitric oxide or other medications based on the need.
The next question, sir.
Yeah.
In your conclusion slide, you had put milrinone should be used once, inhaled nitric oxide prolongedly used.
Yeah.
But according to the echo, if diastolic dysfunction is noted early, you can start milrinone. Is it correct?
You're absolutely right. If I would have mentioned that, that's not right. Milrinone can be used along with nitric oxide. It's not that, but you use milrinone only if the ventricular function is not good, provided your systemic blood pressure, the mean arterial blood pressure is not below the pulmonary arterial pressure. See what happens if you use any. You see, milrinone is just not anodilator; it also vasodilates. It's not a selective pulmonary vasodilator, so it can cause systemic hypertension. So if your systemic pressures becomes low and the pulmonary pressures are quite high, then it can enhance more right to left shunting and deoxygenation. That itself can cause more trouble. So if your blood pressures are quite decent and you know that pretty sure the pulmonary pressures are isosystemic or less than the systemic, then you have ventricular dysfunction. You can think of using it.
Sir, the next question is pulmonary hemorrhage while managing PPHN. How do you handle?
Well, we have to handle it's quite a tricky thing and it's quite a tough thing. Hopefully, pulmonary bleed, you cross your fingers and say that, okay, it probably stops over time. The management still remains the same. The pulmonary bleed is one which is going to flood the whole lungs. There's going to be atelectasis. There's going to be surfactant deactivation. And along with that, the pulmonary hypertension. So you need to manage as such, if there is coagulopathy, you need to rule out why is it. If there is a PDA which is causing pulmonary hemorrhage, you probably need to think, okay, I control the pulmonary bleed, then what should I do for PDA? Or if it is something related to sepsis, if it is a DIC, probably that's a nasty condition where you probably, is the sicker of all what we think. You may have to think of using FFP, vitamin K as a supportive measure, appropriate antibiotics, and hold the baby having a good saturations or a decent saturation with a decent pH of more than 7.25 with a preductal saturations of 90 plus and a PaO2s of around 50, 60, I would accept and wait till the baby settles
down. Sir, what is your opinion on usage of dobutamine since it causes myocardial dysfunction in PPHN? Why is it still used in low doses in PPHN as recent studies showed it causes vasoconstriction?
Well, if you look at dobutamine, basically it is a selective cardiac, contractility, and of course, if you use it on higher doses, it does cause pulmonary systemic vasodilatation too. You have only two medications which can help for your myocardial dysfunction, either milrinone or dobutamine. But if you use any other vasoactive agents like dopamine or adrenaline or epinephrine, it's more of peripheral vasoconstriction. But as you rightly said that, I'm not pretty sure why it is not used, but most of the centers do use still. But probably I need to look into it more detail why, particularly in PPHN, shouldn't be used. But what I have the information or whatever I have read through, I've experienced through, we generally don't use dobutamine. If you want to increase the systemic vascular resistance, we just use adrenaline or non-epinephrine. And we use milrinone if the blood pressure is good. Very rarely we use dobutamine.
Sir, there is one more question on that line only. Should we maintain systemic BP or mean BP more than pulmonary pressure to achieve target saturation?
Well, I would probably look into, see, if you're measuring the pulmonary pressure, the systolic pressure is the mean pulmonary pressure. If you're measuring, then probably you can think of keeping the mean pulmonary pressure below the systemic pressure. But if you're measuring the arterial line, the mean systolic pressure is quite good and the pulmonary pressures are low. I'm happy with that. Anything little bit of more than that should be good. So what we need to do is at the same time assess on echo if it is predominantly what type of shunt it is. So if it is bidirectional, then I'm okay with it. But I don't want the shunt to be right to left, which generally and causes more severe vasoconstriction and causing more severe pulmonary hypertension. So I would be okay with it if it is ISO or below ISO, not more than systemic pressures.
A comment on milrinone. We have used milrinone very often. That is from Dr. Sanjana. In our experience, if BP is low, it can be countered by adding noradrenaline to counter BP. And second option is to avoid milrinone bolus and start direct infusion. Your opinion, Devas, sir? Well,
milrinone bolus generally it is not recommended if you're managing in PPHN. This is kind of a general statement. If you want to start milrinone, especially in the cardiac patient, they would give a bolus and then top up with the infusion over time. So if you're starting milrinone, you can straight away start as an infusion, either as 0.33 or 0.5, probably to start with, and then you can escalate. In terms of milrinone, using use of milrinone and causing systemic hypotension, then adding non-epinephrine. This is where it is a tricky thing. So if you want to bring the systemic vascular resistance up, at the same time you want to improve the myocardial function, and also hope that milrinone also helps at pulmonary vasodilatation, you probably can think of using that. But you can't keep on jacking up these inotropes thinking that it will improve for the next 1 to 2 days. Because a lot of people, they start, let's say if you start epinephrine or non-epinephrine at 0.02 or 0.03 mics, then if you don't see a improvement, you keep on going up to, I've seen going up to 2.2 mics, even 0.3, 0.4. That's quite a huge ton of inotropes when you use more than 0.1 actually. Most of this, pressors, if they really act, they act even at 0.05 mics per kg per minute. So titrating these inotropes is very important. And if you are using it, you need to be next to the bedside, achieve what you want to do, document with the echocardiography if you have the facilities, and then that is okay.
Sir, there is one more question. Nitric oxide is shown to be oncogenic in recent studies. So we should be moving away from nitric oxide. Dr. Kishore Kumar sir has asked this question.
Fantastic, Kishore. Well, we have only left with this. If you want to save the baby right now, probably you have left only with nitric oxide. Yeah. As we heard, oxygen is the best, pulmonary vasodilator 20, 30 years back when I and Kishore were doing neonatology. We never thought that oxygen one day we'll talk about, using as less as what it is. I'm sure over time, as the more papers come in, if it is teratogenic or carcinogenic, probably probably will think of not using it, or what is the dosage we should use, which is less carcinogenic, we'll look into it. What we are using is 20 parts. We don't know, we might use only 5 parts or 2 parts. Anyhow, we know that we have endogenous nitric oxide production. So we may have to use a little bit of nitric oxide, which opens up the pulmonary vascular bed.
Sir, how often you see primary PPHN? How different is the management in this case?
It is not very quite often if you look at the statistics, but we do get, out of 10 cases, 1 case. Recently, we had a couple of babies over the last year where the ductus had closed in utero. And when these babies were born, there was severe pulmonary hypertension. The right ventricle was as stiff as you would see in a classical tetralogy of physiology. And we did the standard care. And when we did the echo, we found that the ductus was closed. We tried to open the ductus, it didn't open. So what we started doing is try to achieve a pH of more than 7.25, except, PaO2 is around 50 to 60. And we used nitric oxide for 2 to 3 days. It didn't show any difference. We stopped that and started coming down on ventilatory settings, everything. The gases were fantastic and there was no problem in terms of acidosis. We extubated, and this baby we followed up 6 months back. The right ventricle started to kind of modify itself. The pulmonary pressures have come down. But this is the baby which went home on sildenafil and has done well. So we do get cases once in a while. And this is where we need to ask maternal history of drug usage like SSRIs, non-steroidal anti-inflammatory drugs, which can provoke all these things.
So there is one more question. How frequently we should be doing echo when baby is on inhaled nitric oxide or HFOV?
Well, echo is basically a diagnosis to start with, to diagnose the structural heart defect, if there's anything, and to make sure the pulmonary pressures what you want to look at it. So you start your therapies. But if you think that there is a problem with the myocardial contractility, probably you can think of, in our centers, we do it every day, or sometimes we may have to do it twice a day if the pulmonary pressures are not falling or the systemic pressures are coming down. Just to see the myocardial contractility, we may have to do it twice a day. It all depends. If like Prashant, like you and few other neonatologists who are trained in echocardiography, you can always think of doing. What is most important is you shouldn't try to jump and keep on doing it, because that itself can cause pulmonary reactivity and increase in pulmonary resistance. So try to use it, but try to use it as less as often if you're sure about it. But the number is not that you can use it based on your clinical judgment.
So there is one more interesting question. Why nitric oxide should not be used in normal preterm baby less than 34 weeks, but at the same time in preterm babies with sepsis or with a history of PPROM, inhaled nitric oxide is used?
Well, this use of nitric oxide in borderline preterms or less than 32, 34, 35, 36 weeks is been extensively studied over the last 5 to 10 years, I can say. There was one time where we never used nitric oxide with the preterm. Well, we know that nitric oxide, when you look at the whole anatomy of how the pulmonary vascular bed is formed at the various gestation, there's not much of pulmonary vascularization which would have happened as early as 32, 34 weeks. And the effect of nitric oxide on those pulmonary vascular bed and how it's going to improve is unknown. Second thing is the pulmonary hypertension in preterm babies is entirely different. It's mainly probably because of the pulmonary, the way the alveolization and capillarization happens and causes the PPD. In those babies, whether use of nitric oxide is a questionable thing, though some centers try it out in acute crisis. But whether there are some reports of use of nitric oxide and ventilation and other supports during acute and causing intraventricular hemorrhage. So I don't have personal experience of using nitric oxide in preterm babies, but I'm sure over time, especially in BPDs, congenital diaphragmatic hernias, where nitric oxide has not been quite useful, probably we would come up with something which might not help, or we might give a try. So I'm not sure about um, I don't have personal experience, neither I use in preterm babies. But whatever I
Sir,
said is more of theoretical knowledge of what I've read through papers.
So one last question for the day. In pulmonary vein stenosis with PPHN, why is there left to right shunt through PFO?
Well, that is that's the venous hypertension. What is most important to my colleagues is the most difficult part in diagnosing PPHN when you have pulmonary vein stenosis, or a total anomalous pulmonary venous drainage. So you need to make sure that when echocardiography is done and you know that the lungs are not doing what you're expecting, that saturations improve, but you're thinking of PPHN, but the structure of the heart looks good. You need to ask your cardiologist or yourself when you're doing an echo whether you have seen three vessels which are draining into the left atrium. So the three pulmonary veins, that's a compulsory, kind of a thing which you need to look at it. So if all the three veins are draining into the left atrium, then you know that, of course, the pulmonary veins are draining into the left atrium. If you have any suspicion of that, you need to make sure that there's no pulmonary vein stenosis, either proximal or distal, or there's no total anomalous pulmonary drainage. The main problem here is the blood which is supposed to come to the left atrium is flowing back to the lungs. So you're getting into pulmonary edema, and it's more of a pulmonary venous hypertension than a pulmonary arterial hypertension. So the left atrium is enlarged. So when the left atrium is enlarged, you see backward flow. That instead of right to left, you see left to right. And this is where it's strongly indicated you don't need to use, basically nitric oxide, because it is a selective pulmonary vasodilator. So you're going to flood the lungs more.
Sir, one last question. This is the final question for the day, and then we'll close the session.
Sure.
I would like to know all the details of PPHN from the expected antenatal to birth. Any information regarding idiopathic causes for PPHN?
Causes for idiopathic PPHN.
Yeah, probable causes.
Probable causes for idiopathic
before labeling it into idiopathic.
Well, you rule out all the structures of the heart. You rule out all, like you don't have a history of meconium aspiration, you don't have a history of RDS, you don't have history of pneumonia or sepsis. Then the lungs look good, but the baby is still hypoxemic. Then probably you have to think of idiopathic caused as pulmonary hypertension. And usually these are the ones, where we don't find a cause.
Can I ask one question?
Yes, sir. Yes, sir. Please go ahead, sir.
Dr. Prakash?
Hi, Dinkar.
Hi. See, you told steroids is not, methylprednisolone is okay in inflammation, but there is 12 cases studied in Andhra Pradesh with a severe PPHN. 12 cases studied in totally 153 cases. In that, they have done everything without ECMO. They have done nitric oxide, they have put on HFO, whatever the things, they have done it. But they have not improved. Only thing was ECMO patient attenders were not affordable. So they started steroids. Many babies were improved. Then they came and they were about to send for the what could be the reason. Then when they have sent the blood and the bit of the lung biopsy, then they found out it was a pulmonary glycogenosis, pulmonary. So only treatment is steroids. So they have studied in Andhra Pradesh, Vijayawada, Noori Children's Hospital.
Right.
12 cases or 13 cases. So steroid in case what I felt is, in case everything is done before ECMO, not affordable, I think so we can even start. But the newer thing in PPHN, what Ramaswamy Ranganathan is telling, even steroid can be used early also, there is no problem, even in MAS. What is your conclusion? Last I told you, then first even in MAS we can start. What is your conclusion?
See, that is what you see. Let us look at MAS first. It meconium aspiration syndrome. You know that it is meconium, so we're not sure. How the baby. We have seen extreme forms of meconium aspiration syndrome. Some would just improve by just CPAP. Let's say if it is severely bad PPHN with meconium aspiration syndrome, and if it improves without any of this, great. We also know that meconium aspiration causes chemical pneumonitis and this extensive inflammatory thing which is happening in the lung. So the corticosteroids do has anti-inflammatory properties. But make sure that this baby's blood cultures are negative, the counts are fine, the CRP is fine. If you are using procalcitonin levels, check those levels. And if they're all fine, there's no harm. By giving 1 dose or 2 doses, I don't think so it will kind of knock the baby off. So sure, you can use. But let's say in Visakhapatnam, what the people have done is for 12 babies. But what I would like to pass on the message is that, don't use steroids straight away. I kept it as the last. That is the last resort. If you have used everything, think of using corticosteroids. And if it makes a difference, great. But again, having said that, even if a child is going on ECMO, they prime the babies on steroids to suppress the inflammatory mediators. Because it's a heart-lung machine, the circuit will be primed. So these babies will release a lot of cytokines. So they want to suppress, they use steroids. It's not that. So you can use 1 or 2 doses of steroids and this doesn't make difference. The OI index is very high. And if you think that, okay, this child will benefit with ECMO, probably you can use it and send it to other centers.
Yeah, in the last, they have used it for pulmonary glycogenesis. Later, they came to know once the baby is improved.
Yeah, that's again, kind of a thing which you can't make it out clinically. It is more of using a trial and then retrospectively trying to work out your diagnosis, why it made a difference. But in a majority of a clinical setting, you don't see that as the first diagnosis.
Thank
Hi,
you.
Prakash. Good evening. Dr. Guru Prasad from Davangere. Yeah.
Sir, namaskar, sir.
Yeah, excellent talk. I think you have covered most of PPHN, which is very practicable for a state like ours. Your topic was very clear, how to manage it in a level 2 unit.
Thank you,
The
sir.
gold standard is INO and ECMO, but
Yeah.
still it is far from clinical practice. Only people who are working in Bangalore and cosmopolitan cities can think of it. But the last 30 years working with this is a nightmare. Clinical management of PPHN is a nightmare for the entire team in any hospital. I think what I really appreciate, you covered most of it, especially emphasized on the ventilation. And I think sildenafil is something that is to be considered in resource limited settings with close monitoring. And another important thing is good sedation. I think you mentioned maybe fentanyl or morphine, and muscle paralyzing is the choice of the unit. Because most of these are term babies which are very vigorous and very labile. I think ensuring good sedation throughout the ventilation is a very challenging task. Anyway, it was nice hearing to you, Prakash.
Thank you very much, sir. So, like a lot of people do think nitric oxide does miracle, but if you look at the data of use of nitric oxide for whatever cause of PPHN, 40% of them don't respond, which I thought I'll discuss next, presentation. So still 60% of the PPHN management just happens with whatever has spoken. I'm sure out of that 50 to 60% of the babies, if you just do the basic thing from the start, would improve, because majority of the chunk of PPHN is because of meconium aspiration syndrome, RDS, PTN, and infection in our country.
Most of the drugs that were discussed in the course subsequent to your talk have been explored quite early in PPHN's history. Most of the drugs, including steroids, all that, again, they are coming back in a selected population. But it can't be extrapolated that steroids are going to be changing the clinical practice of PPHN. I think we have to wait for larger number of patient study.
it's kind of, it suppresses the anti-inflammatory property. It has anti-inflammatory properties. Probably, it helps in little bit of child getting better. But as Dinkar was mentioning, you need to, if you're clear about the diagnosis by any means, either by molecular testing of these genetic conditions, you can't use it just to start with. Another thing which we over time as a neonatologist would face is babies who are born with alveolar capillary dysplasia or malformation of the complete vascular bed, or babies who are born with trisomy, Down's babies with PPHN. Their pulmonary architecture is entirely different, and the management varies from unit to unit and person to person. So those are the challenging babies, and diagnosis only happens by lung biopsy.
Yeah, sir, thank you. Thank you very much, all of you. So we would like to announce as well that this academic session will continue till next 1.5 months. We have made a very good schedule with all excellent speakers. Plus weekly, we'll be having one international speaker who will be speaking on neonatal topic. So it's going to be really interesting. I request all the participants to participate in the session, and people who are interested in neonatology. This is going to be all exclusive neonatal webinar sessions, what we will be planning from NNF Karnataka. So I request all the participants to encourage their postgraduates, colleagues, and other interested neonatologists and practicing pediatricians who wants to learn more about neonatology to join us. Sir, thank you very much. It is always pleasure listening to you. You are a fantastic speaker. Everything you have covered with utmost patience and ease. Thank you very much. We would be publishing this in a Facebook page by tomorrow, and even in YouTube channels as well. So whatever we'll be doing session from our NNF Karnataka, it will be made available for the public, so everybody can view and learn and get knowledge. Thank you very much. And I would like to thank all the seniors, Ranjan sir, Guru Prasad sir, Kotreshi sir, Kishore Kumar sir.
Good luck, sir.
All of us.
Prashant, wonderful.
Prashant, Koturesh, we really appreciate your initiation. We were feeling lost because of the lockdown. I think it's very encouraging that these sessions are happening.
Website. Fine, sir. Happy to do all the things.
We have, sir.
Sorry.
The last special team has been organized a wonderful organization by Prashant and Dinkar, and thankful for Prakash for collaborate of pathophysiology of PPHN and management at the level 2 care. Thank you, sir. Once again.
Thank you very much, sir. Thank you for giving me this opportunity. I got the opportunity to listen to a few of my senior colleagues and teachers who are my guide throughout my career, and my close friends, my colleagues. So it's fantastic, Prashant. Thank you.
Thank you, sir.
Tomorrow we'll be having our echo session, echo findings of PPHN and PDA by our favorite Dr. Venkatesh sir, and Sidhu will be discussing on case discussion. Please join us. And on Monday and Tuesday, we are having Guru Prasad sir's most interesting and most requested topic, that is art of newborn examination. Kindly do join us. I'll be publishing the schedule by today evening.